You've got the gear in your hands. Now the question is where to put it, and that choice matters more than most beginners expect. A good vein turns a clean first stick into a reliable line. A bad one turns into a blown vein, a soaked arm, and a patient who flinches the next time you reach for them. So in this section, we'll map the veins of the hand and arm you'll actually use. Learn the one rule that protects all of them, start distal and work proximal, and sort out which site to reach for when your patient is stable versus when they are crashing. Let's build the map from the wrist up. On the back of the hand sit the dorsal metacarpal veins, draining into the dorsal venous arch, small, but the place you'll start most of the time. Climb to the forearm and you meet the two big players. The cephalic vein runs up the thumb or radial side, and the basilic vein runs up the little finger or ulnar side. Between them, the median antebrachial vein runs up the middle. Caroline groups these as the dorsal hand veins, the radial and ulnar veins of the distal arm, and the cephalic vein climbing into the proximal arm. Now the front of the elbow, the antecubital fossa. The standout here is the median cubital vein. Large, often visible, easy to palpate, and it bridges the cephalic and basilic systems. Caroline calls the antecubital veins the readily available site for a patient who needs rapid fluid, is in cardiac arrest, or is otherwise unstable. But there's a catch: it crosses a joint. Every time the elbow bends, the catheter kinks and the line slows or stops. So the antecubital is a fantastic emergency vein, and a frustrating long-term one. Pick it on purpose for the right patient, not just because it's the easiest to see. Here's the rule that ties the whole map together. Start distally and work your way up the extremity. Picture a ladder. The bottom rung is the back of the hand, the middle rung is the forearm, the top rung is the antecubital. You climb upward, and here's why the direction is one way. If a distal site ruptures or infiltrates, you simply move up to the next good vein above it. But if you blow a proximal site first, any fluid you push lower leaks out below the damage, and you've spoiled every site beneath it. Start high and you can lose the whole arm. Start low and you keep your options. So what does a good vein actually feel like? Run the checklist with your fingertips, not just your eyes. Look for the straightest section you can find. A straight run gives the catheter somewhere to sit. It should feel firm and round and spring back when you press it. That bounce tells you it's healthy and full. And it should be well anchored, not rolling away under the needle. Those big, bulging veins can deceive you. They roll side to side and you miss. The fix is manual traction. Pull the skin taut to lock the vein in place before you advance. Just as important is knowing what to skip. Avoid valves; they show up as small bumps in the vein, and bifurcations where one vein splits into two. A catheter won't thread past either, and the needle can do damage there. Avoid sections that cross a joint, for the kinking we talked about. And avoid a whole extremity that's edematous, injured, infected, or paralyzed. Along with two, you must commit to memory. Never use an arm with a dialysis fistula, and never use the side where a mastectomy was performed. Lymph drainage and circulation on those sides are compromised, and in Roman 4 they can cause real harm. Now put the patient in front of you and let their condition pick the site. Stable patient, routine line. Go distal, the hand or forearm, an 18 or 20 gauge, somewhere that won't tie up the elbow. Hospitals actually prefer those non-joint sites for exactly that reason. But a crashing patient, major hemorrhage, shock, cardiac arrest, needs volume fast, and flow depends on a fat, short catheter in a big vein. That's the antecubital, with the largest catheter that fits, often an 18 gauge or bigger. In a true emergency, you take the readily available vein. Refinement is a luxury of stable patients. Let's lock it in. The map climbs from the dorsal hand veins and arch, up the cephalic on the thumb side and basilic on the little finger side, to the median cubital at the elbow. The rule is one way. Start distal, work proximal, so a failed site never costs you the ones below it. A good vein is straight, springy and anchored, and you steer clear of valves, bifurcations, joints, and any arm with a fistula injury or a mastectomy on that side. Stable means distal and small. Crashing means antecubital and large. Choose the vein before you choose the needle. That's vein selection, the anatomy under your thumb and the judgment behind the stick. Next section, we put a needle in one of these veins for real. The venipuncture procedure, walked through the way the NREMT scores it. Everything you'd read more on for this section is on screen.